Are you connected? Are you informed? Get in the know and keep abreast of what you need to know. Community Health, hosted by Alvin Simmons. Join him. Get informed with Community Health on V100.9. Welcome to Community Health. Community Health is it is designed with you in mind, talking about issues valid to you in your community. Today, of course, is our host, as always, Alvin Simmons.
Hi, this is Alvin with Community Health, your locally broadcast program about the health events in the state. Our sponsors are the University of Arkansas for Medical Sciences, Habibis Incorporated, and AFMC, Arkansas Foundation for Medical Care. If you would like to become a sponsor, please drop me a line. We will be back with the health announcements we have thus far. Today on Community Health, we are going to try to discuss monoclonal antibodies. Dr. Terry Yamauchi sent me an article that was dealing with this, and we were going to tackle that subject, but I found this information and I think it is rather good, so we're going to share that with you today, and we'll come back with some future programs dealing with the oral products. Just a few pointers. There are presently about 4 monoclonal antibodies for infusion on the market. Regeneron is probably the most popular one, and that appears to be the one that's available for use in Arkansas. There are several drugs, oral drugs, that are available for prevention of hospitalization from COVID exposure. Several of those are on the market or will be coming on the market, and as compared to the COVID treatment, it is much cheaper. So that, of course, as in all cases, would be a better form of treatment if it is effective. More on all of these products in the coming weeks and days as we learn more about this. But sit back, relax, and listen to the following program. I think you will find it very interesting and informative indeed.
But we've got some important information to share during this public health pandemic and emergency about monoclonal antibody treatments and prevention therapy for our patients that are going to ultimately save lives and reduce hospitalization. So a few of our key guests that will lead the conversation today, of course, Dr. Nikki Hilliard from the Arkansas Pharmacists Association has been running lead from our office. Dr. John Kirtley from the State Board of Pharmacy, who everybody in Arkansas knows, and from out of the state, a lot of you know John as well because he's a leader on a national level with both ACPE and his involvement with NABP, and a former APHA ASP national president when he was a student as well. So thank you, Dr. Kirtley, for being here. And then Dr. Katari is our lead infectious disease doctor and physician from both UAMS and Arkansas Department of Health, who is running lead on the medical support for the use of monoclonal antibodies across the state of Arkansas. And then Dr. Jennifer Dillahay, Chief Medical Officer from Arkansas Department of Health, and also Medical Director for the immunizations and vaccines for the Arkansas Department of Health. And then Elizabeth, who just said hello, Elizabeth Woodland, is it Barella? Is our, Barella. Hey, Elizabeth.
Hi, sir.
She handles, I don't even want to attempt to describe what all she handles, but she is a key contact for workflow, website updating, and information about launching and offering monoclonal antibody services in Arkansas from the Arkansas Department of Health.
I think, as John and I have discussed, this has been a very trying time, I know, for a lot of pharmacists, and we've had a lot of interest in how we can help in our communities. And two things I would point out, first of all, is he and I talk a lot, and I think worry a lot. We know exactly how stressed out our profession is right now and how trying COVID overall has been through shots, immunizations, and everything else. But when we have looked at these monoclonal antibodies over time, we kind of came to a couple of conclusions that are fascinating. We discussed with the Department of Health, with Dr. Kathari, and I've had a couple of conversations with monoclonal antibodies that even for people that either are not eligible or are not interested in vaccine, that this is an absolute game changer, that these monoclonal antibodies are a passive immunization that can give them the defense that might help prevent hospitalization or further care from being needed. One thing that is fascinating with this is the fact that it can be done outside of a hospital setting. It can be done outside of a clinic. And I know Vincent, I'm sure he'll be back in just a minute. We hear a lot of people saying, where can it be done? How can it be done? Kind of what are some best practices? I've gone ahead and posted in the chat also the link to the COVID-19 section of our website with the Board of Pharmacy. There are two important documents that are new there, one of which is kind of our overall explanation on the different ways that pharmacists can engage in this. And the other one is actually the COVID-19. Here we go. I've actually got a printed copy myself as well. Federal Response to COVID-19 Monoclonal Antibody Playbook. For any of you that are interested in the monoclonals or already delivering monoclonal antibodies either in a hospital or community setting, whether that's in homes, in a separate facility from a pharmacy or anything else, that playbook literally spells out kind of step by step what are the things that you really need, what are some of the stressors that are out there for this. John, I was just asking our public health ADH folks kind of their overall thoughts on how these monoclonals might be helping us to save people from hospitalizations and further complications. So Dr. Dillahay, Dr. Kathari, love to hear from you guys.
Thank you. Thanks, John, and thanks, John. I don't see Dr. Dillahay, so maybe I have to just scroll over. But as you mentioned, we've been using monoclonal antibodies now since November of last year, and I kind of see it as almost as two different pandemics. We went through a winter surge, and then we are going through a summer surge right now, almost with two different viruses. And we saw this in the winter surge. Once monoclonal antibodies started coming about, we would very clearly see that they help to blunt the impact if given early. They did reduce hospitalizations. Some of the data from the winter surge was less than 5% of patients who got monoclonal antibodies ended up getting hospitalized. Now, we don't have that kind of systematic data for this summer surge, but again, anecdotally, from what I've heard from all parts of the state, is patients have given monoclonal antibody therapy early on do not get hospitalized. What has been a game changer, as John mentioned, is in the summer, what has been different is the FDA has approved the use of subcutaneous injection for one particular product for use both in early treatment as well as for post-exposure prophylaxis. And the other game changer has been, as John mentioned, availability of post-exposure prophylaxis. So first, let me talk a little bit about subcutaneous versus IV therapy. Most of our established infusion clinics during the winter surge were in hospitals, and they were used to doing IV infusions. So infusions initially were about an hour or so, and as we kind of got to learn more about them, everybody figured out this is very safe. Infusion times kept on becoming shorter. I think these days, most folks who are doing infusions do them over 20 minutes, and then you're supposed to monitor patients for an hour afterwards. So one of the good practices which I've seen in hospital infusion centers is they'll run a piggyback saline for that hour so the patient gets some fluids as well. Now, so IV infusion, like I said, we have established sites, they seem to work well. What the FDA did in late May or early July was approve subcutaneous therapy, and that was mostly based on pharmacokinetic data. And they approved it as an alternate for IV infusion therapy for patients who require early treatment, so infected patients requiring treatment. But they also said that in case you're not able to get IV infusions in time, which may be a delay of a day or so in getting the patient to a location which is able to do IV infusions, then subcutaneous therapy is a preferred route in that case. What also happened in late July was there were results from a big clinical trial from region COVID, which showed that given subcutaneously in high-risk exposures, it helps prevent infections developing in these high-risk exposures. So as John mentioned, now region COVID can be given for post-exposure prophylaxis. The FDA has been very clear in labeling that this is not a substitute for vaccination. And this is specifically not for pre-exposure prophylaxis. So you can't give it if you have somebody who doesn't want the vaccine, doesn't have any exposures, but just wants monoclonal antibodies. That's not approved. But if you have an unvaccinated or a partially vaccinated individual who has a high risk exposure, that's usually for me defined as household exposures. Then they are candidates for subcutaneous post-exposure prophylaxis. It helps prevent symptomatic infections by 80%. So I can't even emphasize enough the role of post-exposure prophylaxis. They can also be given in vaccinated individuals if they have high-risk exposures and are in congregate settings like a nursing home or a prison or a jail. And it's expected that they would not be mounting an immune response to the vaccine. So that's a more nuanced decision which has to be made by the provider as to if a vaccinated person shows up for post-exposure prophylaxis, then are they an appropriate candidate or not? So that's my initial kind of gist to this. And once again, thanks for having me. And I'll see whether Dr. Delahaye has additional comments.
I think you did a good job of covering this. I think this is a real game changer for having these monoclonal antibodies. And I think pharmacies are in a good position to be able to provide it in areas of our state where they're not otherwise available. So I'm just very appreciative of the pharmacists for taking an interest in it and learning about it, because this is how we're going to keep people out of the hospital. We won't be able to vaccinate our way out of the current surge of Delta variant.
And for both you guys, tell me if I'm off base on this, but I've almost described this as we got some criticism on some of these national forums of mainly Facebook armchair quarterbacks that, well, we should not be doing this instead of vaccines. We've all been very clear that vaccination is plan A. This is very clearly a plan B. This isn't, hey, I might get exposed, so I'm going to go get monoclonals. This is, I'm either unvaccinated or I'm vaccinated, and I either have positive test for disease or exposure with risk. And the playbook outlines this, but I've tried to be very clear with people. Vaccination is plan A. This is plan B. And even for some of our vaccinated people, this still is a game changer to help prevent hospitalization. I'd love to hear if you guys have feedback on that.
So the way I kind of think about this is actually try to talk about the flu. We have a flu vaccine. We also have Tamiflu. There's research going on for monoclonal antibodies for the flu. We have different things in our armamentarium for flu. Monoclonal antibodies are first and foremost early treatment options. And post-exposure prophylaxis is an additional role. As you said, John, I think they are complementary to vaccines. They do not replace vaccines. We are very lucky in this country to having this resource available to us. I can't emphasize this enough that we need to utilize this to help patients, because eventually, if somebody with flu comes in, I'm going to give him Tamiflu. You can't not give him Tamiflu. This is really strong data backing up the role and the efficacy of monoclonal antibodies in preventing severe disease. So that's how I see this. Dr. Delahaye.
I don't really have much to add, Dr. Katari. I think that it's a both and at this point. We have got to keep people out of the hospital.
We're out of beds.
Yeah.
And, the very limited beds that we have, when we are hearing here at the board, even that we have facilities that 25% of their patient load or higher is all in one disease. We had one pharmacist that I was just having, an instant messenger thing back and forth with. He said that is not sustainable for our healthcare professionals or our facilities, beyond even discussing ventilators.
Yeah.
John, do you have anything else you want to cover on that? I know we wanted to spend some time talking about kind of what you and I have discussed with some best practices and how we kind of see this working in the community, both as intravenous and as sub-Q administration.
Yeah, I'd like to, from your perspective as in the regulatory agency, the things that you worked on last week that were posted on the website and kind of the framework for what the legal authority is to provide the service. And then we could talk about some of the clinical and practical implications and may have some feedback from some of the pharmacists in the field who are on the call, which by the way, I have an updated list. It looks like there's at least 16 pharmacies that have launched in the last 3 weeks, several of these this week in places like Little Rock, Sherwood, Cabot, Pine Bluff, Hot Springs, Heber Springs, Paris, Prescott, Hope Truman, Hot Springs Village, Benton, Ozark, and DeQueen. So we've got
That's great.
wide range of this being launched in about 16 locations. I know of another 10 that aren't ready to announce, but that are close to launching the service. And I'll turn it over to you, Dr. Curley.
Okay. And I'm going to do this pretty quick for everybody just to show you. I'm going to share this part of my screen. If you go to the Board of Pharmacy website, we actually have a big bullet right on the top, COVID-19 pharmacy procedures that has all kinds of COVID information on it. But the two newest things that we put on there, one is about how this kind of works in Arkansas. But I first actually want to show you the federal response, the playbook. And I'm going to generally call it the playbook. I think John is going to do the same thing. When you look through this, let me decrease the size of that a little bit, but it is literally a slideshow of how the EUAs and how the approvals on these actually work. I appreciate Dr. Cathari talking about, what are the indications, and this talks about post-exposure prophylaxis and then active COVID-19 infection. It talks about the indication specifically for these. These are the guidelines that kind of tell you who is and is not, or who should or should not be eligible for this. The post-exposure prophylaxis with RegenCov specifically, they're saying the same thing as us. It's not a replacement for vaccination. This is a temporary bridge that is an additional tool for our healthcare members. When it goes into, and there's actually a real good sheet on this for eligible for treatment for infection, eligible for post-exposure prophylaxis. It's not just everybody that's over 12 that has been exposed or everybody that's over 12 with positive cases. I mean, you've got to see this as a stepwise approach to qualify. We have had some questions. I know John has, and I've heard about it anecdotally separately about for years. Well, what gives pharmacists the right to test for something like COVID? Well, on COVID specifically, there's 2 points I try to make to people. And a lot of these tests, but COVID specifically. The Federal PrEP Act specifically gives pharmacists the authority to test for COVID. In addition to that, most of these tests are CLIA waived tests. So if you have a CLIA certificate of waiver, you have the ability to do CLIA waive tests. It doesn't say you have to be a physician or a nurse or a pharmacist or even a healthcare professional. And oddly, with COVID testing, there are many over-the-counter tests now that they're not PCR necessarily, but they are antigen tests that could also work for this. So it's a positive PCR or antigen test. I'm not trying to endorse a specific one, but many of us have seen the Binax test available at many retailers that people are having to get to travel, to go to different concerts, to go to summer camps for kids and other things. I've got a couple meetings I hope to attend that I'm going to have to show a negative COVID test in addition to the fact that I am immunized potentially coming up. The other risk factors are fairly interesting because it talks about age, it talks about obesity or having a BMI over 25. And, most people, even if they think they're in really good shape, are oftentimes surprised that their BMI is over 25. And it goes through these other things. These are considerations, just like when we talk about booster shots for people that are immunocompromised, that we kind of have to go through a list. So by all means, if you are interested in this and interested in getting involved, this is a great document that really spells a lot of this out really straightforward. John, anything you want to add to the playbook before I move back to our other document?
Well, one thing I would say too, race and ethnicity can be associated with worse outcomes, and probably I may send an invite to Dr. Michelle Smith from the Arkansas Department of Health as well in the area of diversity. She's been a big help for our clinics that have launched. And
so I'm going to back to the Board of Pharmacy page and show you the other thing. It's the pharmacist use of monoclonal antibodies. This is the document that we were working on last week. Scott Pace and John Benson and we had, we're running some of the ideas across Justin Boyd, who is a bill sponsor for some of the updated language that is in statute about pharmacist scope of practice. So the first thing I'll tell you is we are not necessarily endorsing that pharmacists should always just do this alone. We're not saying that this can even be delivered by any pharmacist anywhere necessarily, but there are 3 different ways that pharmacists can be involved in the administration of monoclonal antibodies. First of all, you have to have some sort of a legal order. It could be receipt of an order from an authorized prescriber to administer the immunization, and we're saying it is a passive immunization. The Regen Cove is a passive immunization by basic definition, and I'll show that. You could have some sort of a general written protocol. I'll defer to Madison here in a little bit. I'm going to put her on the spot and ask her kind of how they're doing it since they're doing infusion. Or you could order it specifically yourself. In some instances, we're going to have pharmacists that will want to order it themselves. The case that I was actually assisting someone who had 2 people that shared an apartment together and worked together, were both exposed. One was positive and one was absolutely clearly exposed. And they had 2 different prescribers that were taking care of them. And they both reached out to their prescriber last Thursday thinking, hey, we, after they've heard about monoclonal antibodies and had other risk factors, we really want to explore this. And neither one of them, either Thursday or Friday, were able to get a call back from their immediate prescriber, but yet they were seeking monoclonal treatment. So this week, I would tell them, pharmacists, we've published this, could actually order it themselves if they meet criteria. It's fascinating because we do have a conflict in our rules that you cannot treat anyone under the age of 7, but this therapy is not approved for people under the age of 12 anyway, so we do not anticipate that being a rate-limiting step at this time for pharmacists. We have already spoken to the fact that if you're wanting to do like intravenous therapy or vaccinations or shots of whatever type, once there is a legal order for that shot, for that monoclonal, for that infusion, which in this instance could be from a pharmacist or a physician or a protocol, you could engage with an RN or an LPN to help with that. Most pharmacists do not have the training to do IV infusions. They don't have venous access training, but we are trained for IM and sub-Q shots. Some pharmacists also have the intravenous training from being phlebotomists, from being a combat medic, or being in some other level of training previously, that they do have that training. When people ask how are monoclonals considered a passive immunization, 2 quick definitions that I would point out to, one from U.S. National Library of Medicine, NIH, defines it as passive immunization, passive immunity, passive immunotherapy, all refer to the transfer of antibodies to an unprotected individual for the prevention or treatment of disease. I actually prefer the Encyclopedia Britannica that says in passive immunization, a person receives antibodies or lymphocytes that have been produced by another individual's immune system. In active immunization, the individual's own immune system is stimulated to produce antibodies and lymphocytes. We've also included, for anyone that really want to see what does the statute say, and I've highlighted the salient portions of this section of the Practice Act because it is a confusing sentence to read unless you read it about half a dozen times methodically. a pharmacist may prescribe, administer, deliver, distribute, or dispense. And then it talks about medication to treat side effects, but also vaccines and immunizations to or for a person 3 years of age or older. So on this, treating people over the age of 12, it is covered by the Pharmacy Practice Act in the state of Arkansas under legal authority.
Yeah, let's talk about the separable areas versus a separate, because Dr. Katari, I'd love to hear his thoughts. I know several of those pharmacies are doing it at their pharmacy in a separate area within the pharmacy. And then there are others who have either leased space off-site or they own space off-site, and they're doing it completely in a different building than their retail pharmacy. So I'd love to hear.
Yeah. And again, hark back to something which Dr. DeLay mentioned, I see monoclonal antibodies as being a long-term play that, it's going to help us right now, but we also know that COVID-19 comes in waves. So even once this wave subsides, there'll be other waves which happen. And, I kind of think about this whenever somebody new is trying to do it, for them to think through and see whether it works for them as a process. Which makes it different for me from vaccinations is essentially you're dealing with people who have early infections. So that's why it's important to try to keep workspaces separately. So all the infusion centers which I've seen, and I haven't been to the pharmacies, but I believe the ones which I've set up have had a separate workspace or a separate space from their general pharmacy operations to first of all provide some separation. The other thing which is important, I think, for everybody to think about is making sure that the folks who are working with these patients, there's adequate PPE and knowledge about PPE for them to be able to work safely through this. And essentially with Delta, I kind of always say, if you're seeing a patient with early infection, you should be wearing an N95 mask. The early infections are the most highly transmissible ones. Preferably, the patient should be wearing a mask as well. But if not, at least the provider has to be wearing full PPE, which includes an N95 mask to keep things safe. The third thing I kind of always think folks need to consider is, even with subcutaneous shots, which are easier to give in many ways, you still need to monitor patients for an hour afterwards. So that hasn't changed, whether it's IV or subcutaneous. So having that separate facility where the patient can be monitored separately is a good idea. This question has been asked that, do you need negative pressure rooms? The answer is no, you don't need negative pressure rooms. I could even argue that, you could do it in a common big area where you have multiple infusion chairs or sites where you have a few patients sitting around. The other thing the more common mode which I've seen is single rooms. So, the patient is in a room, they're given the monoclonals, and then they're monitored in the room, either with a camera or just through their phone, or somebody checking in on them every 15 minutes or so. So those are some initial thoughts which I wanted to share. Elizabeth may have other ideas because she deals much more directly with a lot of infusion sites. So I'm going to stop here and see whether other people have thoughts.
Mine is more on the side of, if you are ordering Regeneron, for your facility. Usually we do have a buffer supply here at the health department that I offer folks that, because it may take a few days for you to actually set up your AmerisourceBergen account. So we have a buffer stock that we can actually get to facilities, but also making sure that when you actually go in and request an account to receive Regeneron, that you may get an email and it won't be COVID-19 or Asper or anything like that. It'll actually be an onboarding. That's the email that it comes from, is onboarding. And I noticed that just through troubleshooting with a few facilities that they received the email, didn't realize that that's where it came from. And it's just usually if they are validating the account, they just need the pharmacy license or the provider license to be scanned and put into the system. And they usually activate the account within a couple of days. So if you just kind of keep an eye out for that, that was one of the things that we saw a couple of weeks ago. And then pretty much I usually just send out the information on how to get the Regeneron, and then also the reimbursement piece I get a lot of questions on, but that's for as far as initializing your monoclonal antibody site. That's kind of where I play a factor.
Excellent. Thank you for that. It's awesome information. Just want to throw out too that there are pharmacists and others that are going to patient homes and infusing subcutaneous injection or IV if nurses or healthcare professionals who have training in that route are able to do that at a patient's home, like a home IV infusion company. The rate of pay set by Medicare is a much higher rate for at-home infusion, but then it's harder to scale because you're at an individual's home with a single patient for an hour to an hour and really an hour and a half. For all practical purposes for each individual patient. Is Maddie on from West Side and Benton? I saw her on.
She's on.
And if she is, I'd love to hear from her because they've been offering this service for almost a month now, so about 3 weeks down in Saline County.
And as Madison's getting ready, I'll point out, one question that we have had that John and I know are on the same page between the association and the board is, the board has outlined a legal method. You could do this at a separable facility, and that's what Madison is actually doing, that's separate from the pharmacy. What we've said is just like if you go on site to a school to do a flu shot clinic for their staff, you have to take the prescription products, whatever has that RX legend, and it has to come back to the permitted pharmacy every night. We're not allowing the storage of drugs outside the pharmacy. So some people have been confused. But I mean, I've been in the facility that Madison is using when they were using it as a shot clinic site, and I understand they've transferred. So Madison, we'd love to hear from you kind of how this is working for you.
Yeah. So phones ring all the time around here.
I bet.
Just kind of like a quick rundown of how it's been going. We got the idea originally. A couple things happened simultaneously. I saw Dr. Hilliard's Facebook post about how we were able to start offering that in a pharmacy. And then Blake Torres, one of the owners, got a call from a local physician inquiring if that was something that we offered. So we all kind of brainstormed, came up with the idea. Blake reached out to a couple of contacts at some of the local hospitals. And a couple weeks ago, they were preferring that we use IV for treatment of people with COVID. And so we talked to Baptist, talked to Washington Regional. They all were using IV at that point. And so that's kind of where we started. We hired an RN and a medical assistant. Our RN has years of ER experience. She's really great. And we revamped the vaccine center to be like an infusion center. So at our pharmacy, we own like the whole building, but it is like separate buildings, essentially, like we're at different ends. And we got recliners, set up dividers in between each little station. We have filters, air filters in between each recliner. And we've been, very successfully giving IVs for weeks now.
And Madison, one thing that we've heard some concern from people over is the fact that we know with these types of treatments, there could be a higher incidence of adverse effects from, an IV infusion or from the monoclonal antibodies than we might typically see from flu shots or even the COVID vaccinations. While a lot of that could be anxiety or stress of the patient, we're wondering, like you, I'm sure have like your own little mini crash system in preparation for if something happens. I'd love to hear what you've got.
Yeah, we do. So the nurse, she was very strict. She was like, I need some Medrol or Solumedrol. I need famotidine, Benadryl. So we have all of that we're able to push IV if needed. And we actually, I guess we were expecting to have a higher incidence of reaction just based off what I'd seen. And, monoclonal antibodies, they're like foreign made proteins. So if you're going to have a reaction to anything, it will be this. But we actually haven't had anybody have a adverse reaction to the infusion. The one that we had, it was definitely an anxiety situation. And the patient was having cardiac pain before they even got hooked up to the IV. I really think they were so far progressed into COVID that they needed to go to the hospital anyways. And I guess I would say that's the main thing we've noticed is as you get closer to that 10-day mark, if you have COVID pretty bad, it just might not help. We've had a couple of cases of them being kind of on the border, and it does seem to worsen it a bit, which that is part of the EUA. If you're needing hospitalization or need supplemental oxygen, you can't offer it at all because it is known that it can worsen it once they're so far progressed.
And Madison, I think that's a great point. And that is the fact that we will see patients that think this is their last ditch effort to avoid going to the hospital, but this is really intended for before those symptoms are major symptoms, when they are mild symptoms or you're even asymptomatic, but with a positive test. So I'm sure you kind of have the plan of if someone comes in with labored breathing and their heart rate's up and everything else, at some point you have to punt. We have to expect this is not an emergency care situation for pharmacists. And oftentimes it's going to be a link for us to really partner with our other healthcare providers, our physicians and hospitals to punt. So kind of how are you guys handling that?
It's really sad. People are calling all the time and they're calling and they're 14 days out from symptoms. And it's terrible to tell someone that, you don't have options. But we even had a call from an ER doctor the other day who was wondering, hey, my patient's about to go on a vent. Is the antibody going to help them? It's not, it's too late. So what we are doing, we're really monitoring all of our patients. The nurses take vitals, every 15 minutes. We get blood pressure, we do pulse ox. If their pulse ox drops, if it's below 90, we're reaching out to the physician who ordered the MAB. And we're like, are you sure? Do you want us to administer it at this point? And, if it is below it's kind of a judgment call on how the patient is, but once it gets to the 86-ish range, we really don't like to administer it because they're kind of getting, the people that I've seen, they have more labored breathing, they're worse off. And so we definitely maintain that close relationship with the physician who wrote the prescription. And I think it's been really good. They've been very receptive and helpful, and it's really helped our relationships with the local physicians. But I think that's going to be a big hurdle for pharmacies being able to order it now and administer it sub-Q. You're going to have everybody wanting it. And you really have to screen them.
You're going to have to tune up your clinical skills.
Without a doubt.
Your assessment and referral and your spotty sense of who's sick and who's not.
Well, and John, that's exactly why I know you and I have discussed the playbook in and of itself is really good about laying out when it is appropriate for people, and it's with mild symptomatology. I think that Madison speaks very well to the fact that we are already getting calls. We're getting them here at the Board of Pharmacy. I know you're getting them at the association. A lot of our pharmacists are. One more thing I'll add, and I know Madison, you guys have worked on this. It's funny, and one of our inspectors, Dr. Fain, was discussing the fact that everybody talks about how they put on PPE, but very few people talk about either getting fit tested for your N95s, which while you don't have to do, if you're really going to be exposed in this way, it is a good practice to do some research into fit testing for those masks. And hardly anybody is talking about not just the donning of the garments and the PPE, but the doffing of it. And that's the taking off the PPE. Because if you're in an exposed environment, don't just take it all off and rub your face because it itches, because you've been that way for a while. I mean, especially I've got facial hair. The last thing I need to do is scratch my beard after I've taken off a mask. You need to go and re-sanitize and prepare and still treat everything that manner. Another thing with this, so Madison, you guys have a location that is just a couple of doors down from the pharmacy, and you've set it up where there are multiple areas for patients so that they are in an isolated area. And my other understanding is the way you've set it up, the chairs and everything that they sit on, they're comfortable chairs, they're recliners, but they are also chairs that can be disinfected. It's not cloth material, it's solid surface that you can disinfect the entire area before another patient or caregiver is in there.
Yes, definitely. It's kind of like I call it kind of fake leather. I mean, it's like plasticky leather, and it can be disinfected before and after each patient. We have like a pulse ox and a blood pressure cuff for each station that's also disinfected. And we keep everyone pretty separate. We have a separate area of our parking lot that we ask people to drive up to, give the clinic a call whenever they arrive, and then they come out to get the patients. Sometimes we have to use wheelchairs to get the patients in. And then we tell the family, hey, it's going to be about 25-minute infusion, then we have to watch them for an hour. And so the family will either hang out and wait, or they'll come back for them.
Hey, John, super quick, because we've got about 8 minutes left. I've got a question about ordering it from Amerisource. They're the only supplier. You don't have to have an existing account with Amerisource to do it. I know that Maddie and Blake set up their account and ordered through Amerisource. There's a fairly easy form to fill out. We did have some issues over the weekend where they wouldn't ship to Arkansas pharmacies, but collaboration with Michael Murphy and Lisa Bernstein at the American Pharmacists Association, we got that resolved fairly quickly. And for states like Mississippi, Oregon, and Arkansas, they are shipping to retail pharmacies who make those requests that need them for their practice. And also have Erin Beth Hayes from White River Medical Center, who's the clinical coordinator and residency director, pharmacist, who's working closely. If Erin Beth, if you're able to unmute, can you talk about low blood pressure, nausea and vomiting, pulse ox less than 92, all that stuff about who to refer as well, to kind of back up what Maddie just shared?
Yes. Can you hear me okay?
Sound excellent. Awesome.
Awesome. So yeah, just to kind of reiterate some of the things that she spoke about, you're going to have patients that come in that are very sick. Most of those patients are probably going to be the patients that are on day 8, 9, and 10. That's where we see these patients come in, and their pulse ox is low, their heart rates are high, they're nauseous. There's lots of things that could be going on with them, and a lot of those things are COVID symptoms. And so you have to assess whether these patients need this infusion, or is this infusion going to make them worse? Are these just COVID symptoms? Are they anxiety symptoms? What we've been doing is just making sure we get a good set of vitals before we ever start the infusion. If their pulse ox is less than 92, we give them a little bit of time to recover in their chair. They may have walked in from the hot parking lot. If they don't recover, we're sending them over to our ER for assessment, because most of those patients, if their pulse ox is less than 92, they're going to need some oxygen supplementation. If you look at the definition for severe COVID in many of the literature out there, they actually say severe COVID is a pulse ox less than 94 without supplemental oxygen. Now, that's not going to be your COPDers. They usually live at a lower O2 saturation, but your normal healthy patients, when it's below 94, that's when they're going to start struggling. So we kind of use that soft cutoff of 92 where we start to reassess those patients. For the nauseated patients, we do have some Zofran ODTs on hand to administer to those patients. Of course, I'm in a hospital setting, so we can do that through orders that we already have. So that may be something you want to work into a protocol if you're going to do. And of course, we have all those rescue meds and things available as well. We've been known to run an EKG machine over there when the patient's heart rate's high, see how they're doing, and go ahead and infuse them. And then there's other times we just send them to the ER for assessment. If you're getting those patients in quick, within the first few days of onset of symptoms, they're usually going to do great. You're not going to have any problems. They're going to be walkie-talkie. They're going to come in, get their injection or infusion, and they're going to do really well. So I do encourage that you try to advertise to get those patients in sooner, as well as screen those patients well. When we first started doing this, we would have people send us patients at day 10, 11, 12, and we did have to turn those patients away and tell them we couldn't offer that infusion due to the risk of them, the outcomes that they could have if we went ahead and infused them. Trying to think if there's anything else. I will tell you kind of with our stats, what we're seeing, we infuse usually about 20 patients a day, sometimes more if it's over a weekend and we didn't do any infusions on the weekend. Our Monday might be heavy with 30 patients. And I was asking our APRN the other day what she felt like was a good number. And it's usually about one patient a day that needs that extra assessment that we maybe send in back to the PCP or the ER for assessment. So maybe 5% of our patients that we get orders on and actually get scheduled to come then end up not getting the infusion and getting an assessment from their physician.
Thank you, Erin Beth. That's awesome information.
So we have started offering the MAB treatments in several of our pharmacies and are administering it sub-Q. It's 2.5 mLs given subcutaneously in 4 different injection sites. So we generally use the back of the arm, either both sides of the stomach, and then the top of the legs, or our 6 spots that we choose from. And again, it's a lot like the live shingles vaccine was. I mean, you pinch up some fatty tissue, and then you push 2.5 mils, and it is a lot of volume. I haven't had any patients just rear back and knock me out or hit me or scream. But it is very strange pushing 2.5 cc's subcutaneously. Some people they don't even notice it. They don't even flinch. And then others, they're I have seen where we've, kind of had a little bubble or bolus, come up. But, I think the important thing is, number one, making sure that, you're protected, making sure that you have your PPE, you have your face shield, you have your mask, you have your gown and gloves, and then, making sure that you're, comfortable with the actual administration, because sub-Q administration is not, in my mind, is not as easy as a IM flu or something like that. It's a little bit awkward. But, after as with anything, after you've done it a few times, it does come a little bit more naturally. But, it is definitely, it's definitely interesting. And just a couple of, pearls. We were told early on by several folks that when the medication is cold, it is very, very viscous and very thick. And so, we try to set it out of the refrigerator and let it sit and get as close to room temperature as we can before we administer it. And that makes it, a little bit easier. But again, we're still learning. We're about a week into this. I do have to, brag on several of our pharmacists. They have really taken this on, and there's been a huge need in a lot of their communities. And, we have been treating a lot of patients, but, as everybody said before, this isn't just another flu shot, or, this is a lot more complicated and there's a lot more to it than just giving somebody an injection. Checking their vital signs, making sure that they're eligible, monitoring them, being ready for any kind of emergency. And, I think it's always good to review your emergency protocols, but the first thing on our list is to call 911, because, you can never have too much help when you have an emergency situation coming up at your pharmacy. But again, our folks have been, have started this last week, and I mean, we've had people that, they begin to feel better immediately. I mean, it is a truly remarkable treatment in that, people can come in and then they can actually leave your pharmacy feeling better. I don't know about you guys, but, my patients normally don't take their antibiotics or whatever right there in front of me at the pharmacy. But it's truly a blessing to get to see the treatment that I do immediately impact and make them feel better. So, again, if anybody has questions or anything, you guys have got my cell phone number. Just feel free to reach out, because, I truly believe that, this is how we're going to end this pandemic. We're in this together, and, anything that we can do to get past this and try to get back to some semblance of normalcy, I think we can all agree that we would like to partner up and team up and collaborate with.
Thanks. So, John, I wonder whether I could mention just a couple of things real quick. One of the things, at least anecdotally, what I've heard from my physician colleagues in other infusion sites is some patients say that they feel worse for the first 24 hours. So I just think, it's good to kind of warn them upfront that you may actually feel worse for the next 24 to 36 hours. And it makes sense in terms of how the pathophysiology of the disease is. The other thing which I want to mention is, and I've heard this from at least 2 other big infusion sites, they have found it easier when they haven't offered an option to patients. So, when you try to do both sub-Q and IV, it ends up becoming more complicated operationally. I think that's something which I thought was smart, and every site is of course different, but something for you to think about. Just offer one particular mode. It may help your operations a little bit.
That's a good point. And the reimbursement and the codes are the same, regardless of whether you do it IV or subcutaneous. And just to give you a ballpark, this is not to say this is what the reimbursement's going to be, but it's somewhere in the $380 to $450 for an in-clinic or in-pharmacy reimbursement. And if it's at home, it's in the $640 to $750 range, depending on who the payer is, and could be less than that, but just based on Medicare rates, those are the kind of the ballpark of what the reimbursements are for each patient, whether it's in clinic, pharmacy, or at a patient's home. There's no better time for collaboration and relationship building between physicians, pharmacists, hospitals, community health centers to work together to provide the best outcomes for our patients.
This is Alvin with Community Health. We want to thank our sponsors again. Our sponsors are the University of Arkansas for Medical Sciences, Habibis Incorporated, and AFMC, Arkansas Foundation for Medical Care. If you would like to become a sponsor, please drop me a line, either email, text, or a phone call. We thank you for participating.